Good afternoon, everyone. Hi, I'm Liz Krueger. I'm the state senator from the 28th district in Manhattan, and I'm so glad you could all join us this afternoon for our specific webinar on the impact of federal cuts to Medicare and Medicaid, their impacts on older New Yorkers, which of course means their families as well. I'd like to welcome those of you who are on Zoom and Facebook or who may be calling in to the town hall on phone. As always, some basic rules of the road. We have closed captioning for today's event. As a viewer, you have to activate closed captioning to view the text on your device. If you're in Zoom, click on live transcript in the meeting controls and start viewing closed captioning. If you're on Facebook Live, you'll see a setting button on the bottom right-hand corner of the video. Click CC for closed caption to activate the process. Even if you just have some hearing limitations, it's amazing how helpful seeing the captions at the same time are for you. As always, this forum is being recorded, and everyone who RSVP'd will receive an email with links to the event video, the resources posted in the chat, and the presenter's PowerPoint, all within a few days. So even though an enormous amount of information is going to come at you in just about an hour total, you don't have to panic about writing everything down, because you're going to get all this information sent directly to you on your computer, and you can watch and rewatch at your convenience. So now we're going to move on to today's event, which, as I described, is about Medicare and Medicaid changes. We're going to hear from a special guest, Fred Riccardi, who's the president of Medicare Rights and a national thought leader on Medicare policy and advocacy. Fred will talk about the impact of the federal cuts to Medicare and Medicaid and how these cuts are going to impact older New Yorkers and our families. There's a great deal of information about the cuts. Some of it is accurate and some of it is not. Fred will offer his best understanding of what the current state of play is, as well as provide you with information to help you avoid misinformation and disinformation about Medicare in the future. Excuse me. He will also offer concrete, actionable steps you can take to advocate and fight for your own health care. We received many questions already, and I'm certain we will get additional questions submitted during the event. Fred will do his best to answer as many questions as time allows. And again, if you didn't ask questions before, you can write in questions to the Q&A section of your system while we're going forward, and we'll try to get to as many as possible. So I want to thank you, Fred, and hand over the mic and the stage, so to speak, to you. Thank you.
Thank you, Senator Krueger. It's a pleasure to be here to speak to your constituents, and I just want to thank you for your leadership and support over the years, and thank you to the office for setting this up. It's a great opportunity to get very important information out there. What I'm going to do now is just take a brief moment to share my screen and share some slides. So just one moment. Okay. Once again, thank you for tuning in and listening. I'm going to provide an update about how Medicare and Medicaid work together and what the federal budget impacts are going to be potentially on these programs. I'm also going to provide some helpful tips and reminders related to Medicare, because I think if one thing that we can all agree on is Medicare is complicated and it's complex, and we're here to help demystify that, to empower people to make independent, well-informed choices. Just briefly about the Medicare Rights Center. Many of you may be familiar with us already and have used some of our services. The Medicare Rights Center is a New York City-based nonprofit consumer service organization where we are set up to help older adults and people with disabilities navigate a very complex healthcare system. And we do this through a few different ways. We counsel people on our helpline, And then we also advocate for them to resolve any issues that they may be having. We also have educational programs. We present information on Medicare and Medicaid and related programs to help people navigate the system and to make clearer choices. And then we take what we learn and then we try to improve Medicare policy at the federal level and also Medicaid policy at the state level. The Medicare Rights Center is also a proud organization that specializes in Medicare counseling for the Community Healthcare Advocates Network, also known as CHA. This program is extremely important because it helps people navigate the entire healthcare system, and we offer free assistance around all questions related to health insurance throughout New York State. That could include medical bills, health insurance denials, questions about enrollment or lapses in coverage. The organizations in the CHA network speak multiple languages. We also have access to interpretation services. And the Community Healthcare Advocate serves the entire state and also runs a helpline. You'll have more information about CHA towards the end of this presentation too. Okay, I know this is the big question that has been on everyone's mind. What's changing for Medicare related to the federal budget bill? The budget bill, which I will refer to as the one big beautiful bill, even though there are many things in it that are not very beautiful, I will continue to refer to it so folks understand how this federal legislation is and is not impacting the Medicare program. And what I'd also like to do is try to parse out some of the other changes that occur within Medicare on an annual basis or as part of the legislative process so we can discern the difference between the two. But I'd like to just do a little refresher. In New York State, we have over 3.7 million New Yorkers with Medicare. Separately, we have nearly 6 million people enrolled in Medicaid. Those are folks also under age 65, not necessarily on Medicare. And to date, we have over 1 million New Yorkers that have Medicare, so older adults, people with disabilities, that are enrolled into something called the Medicare Savings Program, which I'll tell you a little bit more about towards the end of the presentation too. We have roughly 1 million New Yorkers who are eligible for Medicare that are enrolled in Medicare and Medicaid too. So we have a high proportion of individuals that are enrolled into Medicaid, and I'll explain a little bit more about why that is and why that's important and why that's been a real success in New York. I want to step back and just remind the audience about some of the things that we learned in the COVID-19 public health emergency. And we learned a lot, but I'm just going to discuss this from the perspective of Medicare, Medicaid, the Medicare Savings Program, and how these programs intersect. One thing that we learned during the pandemic related to health insurance coverage was that it was a priority to ensure that people remained enrolled in Medicare and Medicaid and their Medicare savings program to ensure they had coverage so they could access healthcare services. Congress had passed multiple pieces of funding legislation, and a requirement that was in place was to keep people enrolled into Medicaid and the Medicare Savings Program. It also helped streamline aspects of Medicare enrollment too. And so what we learned during that was if we make the application process easier for Medicaid, if we waive certain requirements to provide paper documents when that information is accessible elsewhere, then it's easier to keep people enrolled. And so I'm going to talk a little bit about what's changing with document retention, what it's going to be like going forward, and how New York is unique in this respect. But back to the reason that we're here today, and that's to discuss the federal legislation. Congress passed the big bill back in July 2025, and the act does make changes to Medicare and Medicaid law. Some changes impact beneficiaries and enrollees directly, while other changes may indirectly impact people living in a state and the healthcare system and could spur different types of policy changes as a result of some of the cuts. Some provisions in the bill are effective immediately, others take years to fully implement, and I'll show you a little bit of a timeline around that. The bill also triggers big, massive automatic cuts to Medicare unless Congress acts to prevent them, and I'll talk a little bit about that too. But just stepping back, I want to remind folks that the bill was passed primarily to pay for tax cuts. And to pay for those tax cuts, it was one way of paying for them was to look at the spending in the healthcare system and determine where savings could be found. And Medicaid was identified and put essentially on the chopping block to pay for these tax cuts. And there are major changes to Medicaid that are happening. And there are some changes to Medicare too, and I'm going to go through those. But I just wanted to provide that framing for the group. And it would be remiss for me not to mention what's happening right now. We are in the middle of a government shutdown, and we're also waiting for an eventual year-end appropriations bill, which is important. And I just want to mention that I know that there are confusing and conflicting timelines, and it's a lot to absorb right now. And so we're providing information and links so you can really dive into the issues that you're most concerned about. And so there has been previously to the shutdown some bipartisan committee work on some Medicare issues. For example, Medicare telehealth has been wildly popular and supported and a bipartisan issue. And during this shutdown, the telehealth services that need to be appropriated, and they haven't been. And so, currently we're in a pause on submitting some telehealth claims. Providers are still providing telehealth, but there's a lack of clarity on how it will be paid in the future, will it be paid, etc. If we look to the past, in previous shutdowns, telehealth services were retroactively paid, and that's something that we would be advocating for. But we'll come back to this issue in a little bit. I want to make one thing very clear. Cuts to the Medicaid program are also cuts to Medicare. Because what can happen is people go uninsured, they develop chronic conditions, or chronic conditions go untreated. They're approaching Medicare eligibility, and maybe they've been in and out of the healthcare system and health insurance, and they could end up enrolling into the Medicare program sicker. Also, Medicare beneficiaries rely on many of the services and institutions that serve all people with healthcare needs, like hospitals and skilled nursing facilities, long-term care, etc. And that's why we were very concerned about a number of provisions and cuts to Medicaid that were included in the bill. Now, one part of the bill that specifically addresses Medicare is a section called the moratorium on the Medicare Savings Program streamlining rule. So what does that mean? Going back to my earlier slide, we learned a lot during the public health emergency about making it easier for people to enroll in benefits and making it easier for people to retain their benefits. Because we know the more steps, the more paper, the more pages, the more requirements that we put on renewing or reapplying for programs, some people, even though they're eligible, inadvertently drop off the program because they've kind of been caught in this red tape. But what the bill does is it places a moratorium on a streamlining rule. And the streamlining rule was a regulation that made it easier for people who applied for one benefit to be enrolled in another because of very similar, identical eligibility criteria. So, for example, when someone applies to the Social Security Administration for extra help to pay for their prescription Part D drugs, they fill out an application online. They provide a lot of information, their income, their resources. In some cases, more information than what's even needed for applying for the Medicare Savings Program in New York. And so, what this bill does, it required every state in the country that once a beneficiary submitted an application to extra help at the Social Security Administration to get some help paying for the prescription drugs, that information, as part of federal law, has been shared for well over a decade with our state Medicaid agency. And that person is supposed to be screened and enrolled into a program if they're eligible. But most states were either not doing this or just sending somebody a blank application. And so the real goal of helping people who've already applied for one benefit and enrolling into another was never seen into fruition. And so CMS had passed a regulation. CMS is the Centers for Medicare and Medicaid Services. They passed a regulation, but what Congress did was they stopped this. And so states are no longer going to be required to enroll people into the Medicare Savings Program. And the Medicare Savings Program is the program that pays for someone's Part B premium. That's $185 a month right now. And it also lowers the cost of their prescription drugs. It has an approximate annual value of $8,000 a year. And so what the law does is it does not require states to use the information that Social Security has to automatically enroll somebody in the MSP through the state Medicaid agency. But I'll tell you a little bit more in a moment about how New York is a little bit different there. Another big change is there are new eligibility restrictions for people who have been eligible for Medicare, have been paying into the Social Security system. There's big changes there. There's also some automatic cuts that go into effect unless Congress acts. And then importantly, what Congress did not do as part of the big bill was they did not extend the tax credits that people receive that help them afford their marketplace plans. These are the qualified health plans. Okay, so what are the big changes to Medicare? One big key change that we were really concerned about was it did make changes to the eligibility criteria for Medicare. This is a little known fact, and it's approximately impacts about 100,000 people currently. Keep in mind, we have over 68 million people enrolled in the Medicare program. But these individuals, prior to the big bill, if someone was a non-citizen with a legal immigration status, they were eligible for Medicare because they're qualified to receive Social Security retirement benefits. So they've been paying into the system. Or they've been lawful residents in the 65 and over and been living continuously here in 5 years. So what the bill does is it changes a couple things. It does not change Medicare eligibility for people who are US citizens. What else doesn't it change? It does not change Medicare eligibility for people who are lawful permanent residents. These are green card holders. But there are new limits on non-citizen eligibility. This information is going to be circulated after. We have more information that we can share. So this means that some immigrants that are here legally, lawfully present, that have qualifying Social Security quarters. So that means they've been paying into the system. Roughly it's like 40 quarters or 10 years. And this includes some refugees, people who've, seeking asylum, et cetera. They're going to lose Medicare coverage. The Congressional Budget Office estimates that's about 100,000 individuals nationally, but that's really the only figure that we have seen made public. So being eligible for Social Security benefits no longer is sufficient for Medicare eligibility. And so that's a change that's happening. And once we know more, we'll put more information out there. When does this happen? When is it going into effect? The change is effective immediately for people not yet enrolled. Those who are already enrolled, they'll be disenrolled within 18 months. We don't have a firm timeline on this, but the Social Security Administration is required to identify current beneficiaries who will be disenrolled. This is complicated, and we will circulate more information in these slides. So in case folks have questions, you can always reach out to the Medicare Rights Center with any of your questions. We'd love to hear from you. Okay, back to my point earlier. How are the changes in the big bill going to impact people who are duly eligible for Medicare and Medicaid? So these are individuals that meet the income eligibility criteria, and if they live in a state with an asset test or a need to prove that you're eligible and not have over a certain amount of savings, these are individuals who are enrolled if they meet those requirements. So the big bill did eliminate some of the improvements that I was talking about earlier to streamline access to the Medicare Savings Program, Medicaid, Extra Help. Extra Help, again, is that program, really important program. We're entering fall open enrollment right now, and Extra Help pays for the Medicare Part D prescription drug plan. So New York is required to implement auto enrollment for people in the Medicare Savings Program if they've applied for Extra Help. Even if they're not eligible for Extra Help, they still have to be screened for the Medicare Savings Program if they meet the New York's MSP, Medicare Savings Program eligibility guidelines. I have a fantastic chart I'm going to show you in a little bit. Once you see this chart, if you think you're eligible, I want you to call us and be screened for this benefit because it's really important. And I want to mention and thank the New York State Legislature that we were able to work with and become successful in passing this protection in New York. So other states will have some of their residents losing out on having their Part B premiums paid for by Medicaid, but New York will not. The plan is it's still going to be implemented due to a state law. A couple years from now, in 2027, enrollees will see a reduction in the number of months that they can receive Medicaid or the MSP retroactively. So currently, when someone is eligible for Medicaid in New York, and I have those eligibility limits I'll share with you soon, once someone applies, they may be eligible for 3 months of retroactive coverage. Also, for the Medicare Savings Program, for one of the benefits, you may be eligible for 3 months of retroactive coverage. So that means you apply and then you are enrolled in the benefit 3 months earlier. Congress has changed that in 2027 from 3 months to 2 months. Now, the other cuts that could indirectly harm dual eligibles, and this really is going to depend on the state and how the state handles impending losses of revenue and potential budget cuts due to loss of Medicaid funding. They may shift costs to other places and put certain benefits at risk. This could threaten the solvency of hospitals and other providers, such as payment cuts or cuts in the capitation rate. Also, depending on the state that an individual lives in, the state may fund, like New York, home and community-based services. A state may have a loss of revenue and have to cut back on some of those benefits, and all of that is very concerning. It's also too soon to tell. Here's an overview of the implementation timeline. And the MSP rule, so the moratorium or the pause, I like to call it, the pause on that rule for 10 years. CMS, the Centers for Medicare and Medicaid Services, will not be enforcing that rule, was effective immediately. And then you've probably heard about Medicaid work requirements. Medicaid work requirements are not for people on Medicare. I had that question come up in a public forum. But there are going to be work requirements for people who are eligible for expanded Medicaid. That's Medicaid that was expanded through the Affordable Care Act. Those will take effect in 2027. And here are some other key timelines, as you probably have all heard that the big fight over the government shutdown is around in January, the tax credits that lower the cost of someone's marketplace health insurance. Those will have expired if they're not extended, and it's starting in January. And so individuals will be receiving premium notices any day now explaining what their premium would be in 2026, because it would be, absent a tax credit unless Congress acts. And so that's something that we're watching very carefully. And then we just kind of mentioned here where are some of the key points in time. Some of these changes take effect after the midterm election, sometimes before the next, federal election. What else is happening from the federal level for the Center for Medicare and Medicaid Services? So there are some big changes, important changes to the Medicare Planfinder. I'm not sure if you have used the Medicare Planfinder before. You go to Medicare's website, medicare.gov, and you can review drug and health plans. And this is extremely important because we are in open enrollment. And during open enrollment, it's an opportunity to review your coverage. Maybe there is a better choice. One of the key changes coming to the Medicare Planfinder this year, and something that we have advocated for, is that the Planfinder is supposed to include information about networks and networks of providers in Medicare Advantage plans. And so as of this point, we're aware of the premiums for Medicare Advantage plans, for Medicare Part D plans. All of that information is in Planfinder. The Part B premium has not been announced yet, unless I missed a notice and it just came out since 2 o'clock today, but that has not been announced. But we are expecting the Part B premium to increase again this year. And so we're waiting on that information. Also, we have the Center for Medicare and Medicaid Innovation Demonstrations, also known as CMMI. So what is CMMI? What have they been up to? You may, for a few years, have followed some of the demonstrations or the activities of the Centers for Medicare and Medicaid Innovation, most notably here in New York, for people who are duly eligible for Medicare and Medicaid. You may have benefited from participating in a CMMI demonstration related to the rights for people who are duly eligible and enrolled in managed long-term care plans to access something that's called the integrated appeals process. New York had been participating in an alignment initiative trying to make it easier for people who have Medicare and Medicaid or enrolled in a Medicare Advantage plan for people who are dually eligible and receiving long-term care to, access these services. Currently, this plan, the plans fall under the label of the Medicaid Advantage Plus, or MAP. What that means is that's a health insurance company that pays for someone's Medicare, covers their Medicaid services and their long-term care services all in one plan. And there was a demonstration to make it easier for people to access their services by streamlining the appeals process. That demonstration is ending this year, and it was, planned to end over a year ago. So that's ending. But another demonstration that has received quite a bit of attention and concern is a proposed model called the Wiser model. And essentially, what this model does is it tests out a select number of services that the Centers for Medicare and Medicaid Services have identified as being prone to overutilization and other concerns. And they're testing it out in a few states. I do not think, I haven't seen anything where we'll be testing this out in New York. But essentially, what it does is it tests out the prior authorization process in original Medicare for some services. And one of these services is something called a skin substitute, which I'm not too familiar with. Um, and also, certain aspects of um, a individual that has, some procedure that's needed for the knee. And so there's just a few of these services that they're testing out. And what we're, hearing and seeing concerns about is the fact that in original Medicare, prior authorization is extremely limited. For those of you that may remember, it was implemented for, very expensive, high-powered mobility wheelchair devices. But prior authorization is much more widely used in Medicare Advantage, and that's received quite a bit of attention in Medicare Advantage. And so there's some concern that prior authorization is being tested out in original Medicare. While we're on the topic of prior authorization in Medicare Advantage, I just always like to remind people that it's really important if you are enrolled in a Medicare Advantage plan and you have prior authorization for a health service or for a prescription drug denied, that you appeal it. Individuals that appeal their coverage in Medicare Advantage have potential to win that appeal. And there's quite a bit of, reversal of those first denials. And so we really encourage people to appeal, and we can assist with that. Now I'm going to move on to the Medicare Savings Program and Medicaid update in New York. And this is going to be very New York specific because I want to make sure for anybody who's watching right now or watches the recording that you screen yourself for these benefits because you may be eligible and not even know it. Probably to no one's surprise that's listening right now is that the healthcare affordability crisis continues. Medicare beneficiaries spend a significant amount of money on their healthcare costs and their household expenses. Whereas, people with Medicare are spending, up to, 14%, whereas, non-Medicare households spend less than 7% on healthcare expenses, but it's still too much. And generally, half of Medicare beneficiaries are living on around $30,000, $32,000 a month or less. And a quarter of Medicare beneficiaries also have, less than $8,500 in savings. That's less than $8,500 in savings. And this is where, once again, I want to give credit to the New York State Legislature and the governor, of course, for expanding true affordability relief for older adults and people with disabilities in New York by expanding the eligibility limits for the Medicare Savings Program. And this expansion helped more than 250,000 people already enroll in the benefit, and we still think there's roughly 300,000 plus people who are eligible after the expansion went into effect. And so here are the income limits that I wanted to spend a moment, talking about this. You may have received this information if you tuned in to some of the other Medicare updates recently from the Department for the Aging from New York State's HICAP program. That's the Health Insurance Information Counseling Assistance Program. It's called HICAP. That's New York State's SHIP. That's the State Health Insurance Program. The Medicare Rights Center, we're a nonprofit organization. We provide Medicare counseling, and we partner with New York State's HICAP program. We're not the SHIP, but we partner with New York's SHIP, which is the Health Insurance Counseling Assistance Program. You probably know, if you tuned in previously, the star of that program is Eric Hausman, and he's a colleague of mine and has great information. And Eric and I have worked for years on promoting the Medicare Savings Program, and most likely someone who's listening now, we've helped you enroll personally. And so what does this benefit do? And like I said, once the Part B premium goes up, um, the MSP, if you're eligible, will pay for that premium. So currently the Part B premium is $185 a month, and we do anticipate it to go up. And what it also does, the Medicare Savings Program, it pays that Part B premium. It also lowers the cost of prescription drugs, makes them very affordable. Just a few weeks ago, I was speaking to someone who was not enrolled into Part D, was prescribed Eliquis. Eliquis is a very expensive drug, and this person was eligible for the Medicare Savings Program. So we were able to help them enroll. It's going to pay that monthly premium, but it also enrolls them into prescription drug coverage for the first time. That's Part D. Eliminates the late enrollment penalty. For people who may not know, if you've missed your Part D enrollment period, you could be assessed a late enrollment penalty, which is 1% of the monthly premium, average premium, for every month someone was eligible but didn't enroll. But the Medicare Savings Program will enroll into someone into Medicare Part D plan and will also eliminate that late enrollment penalty. It also can help pay for someone if they have a Part A premium, and eliminates a Medicare late enrollment penalty for someone who missed their initial enrollment into Medicare Part B and they weren't eligible for other special enrollment. It's a lot of alphabet soup. So if you have any questions about enrollment periods, maybe you missed one, maybe you want to prepare for one, you don't know anything about enrollment periods, give us a call. We'll talk to you about that. So the monthly income limits, they shot up for the Medicare Savings Program, and we want to get the word out there. So you'll see here for a single individual, they are up to 2,446, for a couple, 3,299. There's no asset limit in New York State. That was eliminated years ago, thanks to the legislature again for doing that, because we know that many people were eligible, but they got caught up in the paperwork having to provide proof of their eligibility. So if you think you're in this income range, or you're in this income range, please consider applying, because our income limits for MSP and for Medicaid went up after the state law was passed. There's no other, state that has really increased the number of people eligible and enrolled in the Medicare Savings Program than New York. And that's because the Department of Health has streamlined the enrollment processes, making it easier when someone turns 65, if they already have Medicaid, to make sure they're enrolled in the MSP. So that's something that we can all be very proud of. So just looking at these numbers here, want to make sure, if your income is below 2,445, $45, maybe it's above that, but you're paying a health insurance premium. That can be deducted from your accountable income and you may be eligible. And so this means, roughly, someone's income around 30,000 or more still may be eligible. So inquire about that. Also, coming in December, New York State is launching an updated Medicaid enrollment system, both for the Medicare Savings Program and certain types of Medicaid coverage that's specific for older adults and people with disabilities. As I had just showed previously, these are the income limits, but these are for older adults and people with disabilities. There's different income eligibility and asset limits for that group. And so the application will be moving online. It's the first time we're launching an online application for older adults and people with disabilities that have Medicare to enroll in Medicaid or the MSP. And the Medicare Rights Center is here to, help you enroll into these programs if you're eligible. So more to come on that. Quick reminder, we're in fall open enrollment. This is the time to review your options, Medicare Advantage or Part D. We are seeing people who are enrolled into Part D plans. There are some plans that are available this year that have low premiums, but if you're enrolled in a plan previously and the premium is going up, you may want to review that coverage. I've just spoke to someone the last 2 days. Their premium is going up $50 a month, and there's a more affordable option for them that still covers the drugs. So they'll want to consider changing. Fall open enrollment starts tomorrow, the 15th, and it ends on December 7th. New coverage takes effect on January 1st. Always inquire even after that period to see if you might be eligible to change, based on your situation. So I don't want people to count themselves out. And as I had mentioned earlier, the Community Health Advocates Program is available to help people with, accessing and getting coverage, understanding their coverage and how it works and what benefits. Accessing care if somebody has received a denial, say for physician services or diagnostic testing or hospital services. What if you got a surprise medical bill and maybe sometimes it's just the provider, is still waiting on the insurance claim and it hasn't been billed yet. And so they're able to help with all of this. The Medicare Rights Center, of course, is able to help you with, all Medicare questions and issues. And if we can't fix the problem, we'll at least explain to you what's happening. And so here's some of the phone numbers that you can call to reach us. I think we just popped the Community Health Advocates helpline in the chat, and then our helpline is here. And so we encourage you to call with questions. We covered a lot of ground here. We covered how does the big bill directly impact Medicare? There's a couple key changes that we covered. We talked a little bit about what's happening at the federal level and at CMS, how New York has made advances in healthcare affordability for older adults and people with disabilities by expanding the Medicare Savings Program. So we want to make sure if you have friends that are hovering around that income level, as an individual around $35,000, that they get screened for the benefit because they may have some healthcare expenses they can deduct from their income eligibility. And then we covered what to do during Medicare fall open enrollment. We know that some of the Part D premiums have gone up. We know that there are still some affordable premiums. What happens if your providers are leaving a Medicare Advantage network? What happens if you want to go back to original Medicare? These are the time of year for these important choices. And based on, what we know right now, at CMS and the testing of prior authorization for some of those limited services that you may not ever use or need, but it is, it is a test of prior authorization of original Medicare. It's only a, demonstration right now, so it is very limited. And there, states may have, ways of deciding that this is not going to, be able to take place depending on who is willing to participate in it. So part of, demonstrations that come out of CMS and CMMI means there has to be a willingness for a state to want to participate in the demonstration. So the most concrete example I can give you is back with the duals demonstrations. This is where individuals were to be enrolled into a Medicare or Medicaid plan with long-term care. Some states participated, some did not. New York participated, then they decided not to, so there is some flexibility there. And just one last you know, reminder about the Medicare Planfinder is one of the key changes coming to the Medicare Planfinder is an individual should be able to look up providers in Medicare Advantage plan networks. But I want to mention if you're using the Medicare Planfinder tool and you're making an enrollment decision for a Medicare Advantage plan and you use the Plan Finder to confirm whether a provider is in network or out of network, and then the new year rolls around and the person is out of network, you may be able to leave that plan through something they call a special enrollment period. But you have to remember when you use the Plan Finder, keep good notes, because if you join a Medicare Advantage plan and the provider leaves the network, based on the information that you access through the updated Plan Finder tool, you may be able to leave that plan and choose another plan or make a different choice.
Thank you, Fred. I'm going to interrupt you just so we can start to get to questions, if that's okay.
Great. And I'm going to stop sharing my screen. Does that make sense?
Yes. Thank you. And I apologize. I know people could have just kept listening, and it's possible Fred would have actually hit on the question they asked us, but we're going to try in just a few minutes to get through a decent number of the questions that people have asked. There might be time for a few more questions, but I'm not sure. And I think you just answered part of one question I was going to raise, which is Medicare the same in every state? And the answer is no, because there's been different waivers that different states have taken over the years. And so we're not even sure if it's going to be the same program rules we had in the past, better yet, other states' plans. But I do want to point out a question that came in a couple of different ways. So Project 25 is apparently they want to default all Medicare enrollees into being forced into Medicare Advantage. And I don't believe that that's a requirement for New York now, although it is a pilot requirement, I think, on 5 states. Will New York legislators be able to prevent this from happening here?
So I can provide a little bit of clarity there. And you know, going back to the passage of the Affordable Care Act, it created the Office of the Center for Medicare and Medicaid Innovation, which is CMMI. And it allows for the office to test out different models in various states that want to take them up to, help save money and create, greater value. And so there are dozens of demonstrations, and so states decide to take up certain demonstrations and not others. And basic rule is an individual has the right to choose between original Medicare and Medicare Advantage. That is a right that everyone has, although there are different rules that do allow for some what we call passive enrollment to enroll people into Medicare Advantage plan. There are notice rights, people can opt out of it, etc. But currently people have a choice, always have a choice between original Medicare and Medicare Advantage. What makes New York unique and a great state again is we have more rights here in New York for accessing something that's called a Medigap or a supplemental plan. We have open enrollment. We're only one of 5 states that lets someone who has original Medicare or has Medicare Advantage leave their Medicare Advantage plan, pick up original Medicare, and enroll into a supplement plan or a Medigap. So very few people have that right in other states. So that's something that, the state has influence over, and it's utilized here, and it's very important, and we're very lucky to have it. I don't see that changing, and I can't imagine there would be any support for that changing because people really, really appreciate it. We do know that those supplement premiums can be costly. Part of the reason it's costly is because we cover everyone who wants access to it, and that's just a great benefit that we have. So I hope that helped answer that question.
Yes. So many people have questions related to, will there be actually just be cuts to what you're entitled to in your Medicare program, such as, are there any changes that will put a limit on how many doctor's visits I can have, or a limit on telehealth visits in Medicare?
So currently, there were not those types of changes in the big bill to Medicare. And telehealth has to be, at this point, has to be medical telehealth, has to be authorized annually. It's not a permanent benefit. It became available to more people in more locations because of the public health emergency, and Congress has continued to reauthorize it, but it's not permanent. Where we are advocating federally for a permanent telehealth visit. What has been made permanent is behavioral telehealth or mental telehealth. Those services are not impacted by this government shutdown. So people can still receive, if you're receiving mental telehealth or behavioral telehealth services.
Thank you. And there's real concern about, now that we're in a shutdown period, will Medicare continue to cover all of our existing healthcare costs? Or is there something that freezes the coverage and we won't get it back?
Well, there is still the need for, Congress to fund the government and pay for telehealth services. In the past, those services, the ones that were provided during a government shutdown were eventually paid. I don't know if the past necessarily can be any guarantee for what will happen in the future, but we would hope that would happen for the providers who are still providing telehealth, that they would be retroactively paid, but it's too soon to tell.
Okay. And we talked about how when benefit changes might happen or might not happen because still stuff has not been completely rolled out. But is there a reason to believe that benefits are changing right away for anyone other than, it sounds like, not US citizens on Medicare at this point?
Well, this is the message that I really want to get out, because I do not want people delaying their Medicare enrollment, delaying enrolling to the Medicare Savings Program because you think you may not be eligible. People who are US citizens are still eligible for Medicare. People who have green cards, permanent legal residents, after they meet the 5 years of, continuous residence, are eligible for the benefit. So based on what the Congressional Budget Office has shared, that for the Medicare population, it's a big number. It's 100,000 people out of the much larger, 68 million plus people on Medicare. It's States will be impacted differently, but for the majority of people on Medicare will not be impacted. Now, Congress did make other changes for lawfully present immigrants who are enrolled in Medicaid, but today we're really focusing on older adults, people with disabilities who are eligible for or enrolled into the Medicare program. Some of the yearly changes that happen too can get conflated with what's happening, whether it's a change in federal law or shutdown, but there are just some annual changes. So we see projections earlier in the year for what the Part B premium will be, what the Part D premium will be. But we like to hold back the final word on it until we have the public announcement that this is the official premium. So even though we anticipate, say, the Part B premium to go up over $200, there's been predictions. Sometimes once that premium comes out, it may be lower than anticipated, it may be higher. That's what happened with Part D. There was an average premium announced late summer, and then by the end of September, the average premium was slightly lower because of some decisions at CMS.
Thank you. And you were talking about Eric and HiCap as your partner in this, and just want you to know, we did a webinar with Eric all about Medicare enrollment, re-enrollment, differences between Advantage, gap programs and traditional Medicare. So for people who have those questions, because a lot have actually come in again, please just go and ask my office to send you a copy of last week's webinar if you weren't on the RSVP list, because a lot of those questions were answered by Eric in the time we gave him. So I'm just not going to go over those many types of questions again, but some things that I don't think came up or were not clear enough for people. So the Biden administration provided seniors with a ceiling of $2,000 out-of-pocket costs for pharmaceuticals. I think for pharmaceuticals. Is that changing in any of the proposals we've seen so far?
That is not changing. And
Right.
so one of the most important benefits for seniors as part of the Inflation Reduction Act was the cap on Medicare Part D prescription drug cost. And so many of us remember the donut hole, which, was the period of time that a Medicare Part D plan would no longer be covering the drug and the beneficiary would be paying, 100% out of pocket for that. Slowly the donut hole changed, but now we finally have a cap in Part D. So that's why it is important when you're, choosing a Medicare Part D plan and when you're paying for your drugs at the pharmacy that you're monitoring that because the plan is keeping track of what's being paid. And we're seeing people reaching that cap in the first month of January, the second month of February. So the law doesn't change that. And the reason the law doesn't change that is because the Inflation Reduction Act actually reduced prescription drug costs for the government also. And so there's savings there. So there was no way to, I'm glad that we did not roll that back.
Got it. So here's a question that always comes up in any health insurance discussion. There's already been a huge amount of concern that despite the law, behavioral health care is not provided with the equivalent coverage as all other health care. Is there anything in the expected or known Medicare changes that will impact getting behavioral health care if you're on Medicare?
There's no changes that I'm aware of right now. I do know that if someone, is enrolled in a Medicare Advantage plan, they may incur some trouble having their care approved for, maybe with prior authorization or some type of denial, etc. And so that has been a perennial issue, but I'm not aware of any other change. I guess the important change was the permanent expansion of telehealth for mental telehealth or behavioral telehealth, which is, being able to receive therapy and those types of services.
So you referenced how for the first time, it seems, being eligible for Social Security was not a guarantee of eligibility for Medicare. But a lot of older adults on Medicare, even though they expect to see some increase in costs each year, it's almost always been relatively matched with the annual increases in the COLA for Social Security. Do we think that's going to continue to be the storyline?
It tends to track year to year that because of rising healthcare costs that an increase in the annual Part B premium bites into the Social Security's cost of living adjustment. The I I'm not sure this year, but generally that cost of living adjustment will take care of that Part B premium. But there have been years in the past that the Part B premium has been higher than the cost of living adjustment of Social Security. And then there is a workaround to hold people harmless for that increase. But I'm not necessarily anticipating that this year yet.
Got it. So this is proverb always the concerns about the increased cost of any kind of health insurance, specifically drug coverage, but two different questions. one names the company, but I'm going to go with that one first. So Aetna bought Silver Scripts, my drug plan now. They are raising my monthly cost from $66 to $116. How is a
Hmm.
$50 a month increase legal? That seems a really big jump in drug coverage.
Yep. So I can explain a little bit about that. And the Part D plans submit bids to the Centers for Medicare and Medicaid Services to provide drug coverage to a set number of individuals within a region. And, year over year, we do see changes in the premiums for drug plans. And so someone may be enrolled in a zero premium plan one year, and then all of a sudden it jumps, $30, $50. This year, there was a cap on, the amount that a plan could be increased by, roughly $50. So we are seeing some of these plans being increased with a monthly premium of $50, but not all plans. And so that's why we think it's really important for people to review their coverage. The, current administration has provided some assistance behind the scenes to keep those plan costs even lower. And so they have been providing a subsidy. It's something that the Biden administration did, and now the current administration. So there is even some assistance happening behind the scenes too. But like
Right.
I said, one year's coverage doesn't guarantee next year's coverage and premiums, and there may just be a better fit.
Right. So this is a question I did expect, and I never know whether it's more of a problem in Manhattan than anywhere else, but as Medicare cuts go into effect, are we going to see fewer doctors willing to take Medicare? Then a follow-up, a second person's question, why are so many highly regarded doctors in Manhattan opting out of Medicare? Because we definitely see that all the time in my district.
Yeah, that's a good question. And that is a question I've received from the district also. And generally what we say, and this is where there are some regional differences, generally what we say is that the most providers accept Medicare, and there is a high, percentage of providers that are enrolled in the program. The it's it is, possible for certain regions that providers switch to concierge medicine or no longer accept Medicare. Maybe they can do this because they have a built-in clientele that can pay for those services. But generally, most individuals cannot, pay out of pocket for a provider and forego using their Medicare coverage, although there's some specialists, such as, psychotherapy, behavioral health specialists that we're pretty much, for many years having to operate without Medicare reimbursement because the reimbursement wasn't there was an inequity. But it does happen time to time. But generally hospitals and providers, they depend on Medicare's payments, and they do stay enrolled, but these regional differences do occur.
Got it. Is there any changes we know of in Medicare law that will impact either eligibility for payments for home care services or nursing home care services?
Right now, I'm not aware of what's happening in the next, what's being planned for the next budget year, what could change, what might change. I know um, that, every year there is advocacy for to keep rates competitive for plans to provide long-term care services and to keep the program funded, et cetera. So there's really not much I can say there.
Got it. Okay. And is there an alternative to afford insurance being the ACA credits will be expiring?
Well, that's the big challenge. I mean, I think what in New York we are, very unique. We have our Medicaid program. We also provide people with subsidized ACA related coverage through the Essential Plan for people who are not on Medicare. We have more generous Medicaid limits for older adults and people with disabilities, which is a big equity issue because we want to make sure that older people have access to benefits too. So you don't, when you turn 65, you just don't lose Medicaid. So New York did the right thing by aligning those income eligibility limits to the 138% of the poverty level. But for the folks who are not on Medicare, who are enrolled in qualified health plans, and if those subsidies are not reauthorized, then they will see their premiums jump. And it depends on the area and the plan that someone's enrolled in. But, we're could be anywhere from $100 to $300 a month, depending on the plan
So in
and the
last week,
state.
right. In last week's presentation, we had a bunch of questions relating to if you've moved out of state and are getting your Medicare somewhere else, or if you're going to be out of state half the year, what it means for you. But today's question is different. If you're in traditional Medicare, can your doctor be located out of New York State?
So if you're in traditional Medicare, can your doctor be located out of state? So if you've traveled to another state, you can see that state. There are, and I'm not a legal expert here, so there's some commerce rules around, if you're in New York but you need services from another state, that person, I think they need to be licensed in a state, but I can't give the full answer to that question. But traveling, that's the big difference. If you're in original Medicare, you
Right.
can go to another state and receive services. So we've, seen people who have a diagnosis and maybe they need service at Roswell Park in Buffalo, Dana-Farber in Boston, and Sloan Kettering in New York to get some opinions.
Right. So what I actually was thinking when I saw the question was, I live along the Pennsylvania border. There's bigger towns on the Pennsylvania side of
Oh
where
yeah.
I live versus New York, or I live along the Berkshires in the New York.
Yeah.
So my Medicare, I'm enrolled as a New York state, but there are more doctors directly across the border
Yeah.
than either Massachusetts or Pennsylvania. So I might want my primary doctor to be one of those people.
Yeah, and that's a good point because we see that with Essex County up in New York State and Vermont. There's quite a bit of that exchange.
Right, right. All right, we've actually come to we're a little bit later than when we're scheduled to end. So we did not get to everyone's question, as I knew we wouldn't, but we covered a lot. And you are a walking encyclopedia of these things. So I really want to thank you for being with us, Fred. And again, you gave all kinds of information about your organization and other sources of information in your presentation, and everybody's going to get all the materials, your online presentation to watch, your materials, references to the different organizations and pieces of information available. And as you pointed out, we only know what we know right now, and we're still in the middle of the process, whatever that might be down in DC. So we're going to continue to try to stay on top of everything, and my office will do its best to continue to send out updates when we actually know facts. And this is a difficult time for all of us. So I want to thank Fred again for being with us. I want to also remind people, if you are interested in other issues relating to federal cuts and other vital services and resources, or the health of our democracy, you might want to attend the No Kings event, a national day of peaceful action, this Saturday, October 18th, which will be starting off at Father Duffy Square, 47th Street and 7th Avenue. It starts at 11 a.m. and we think it's a march to a second location, but we're still trying to collect all the data. But 11 a.m. At Father Duffy Square this Saturday. My office's next event is my in-person older adult resource fair, Tuesday, October 28th, from 11:30 to 2:30 at Lenox Hill Neighborhood House, which is located at 331 East 70th, where we will have more than 25 organizations, including social services, legal, health, and arts organizations, with specific in-person information about their programs and services. We used to do a giant resource fair every year in person, would have up to 80 organizations. Then COVID hit, and we realized you can't put that many people in one place. It's not a good idea. So we're starting up again this year, a little bit smaller, to see how it goes. Our next virtual older adult roundtable is on Tuesday, November 6th from 2 to 3:30. It will focus on federal cuts to Social Security, SSI, SSD. The registration links to both of these events are listed in the chat, And if you prefer, you can register by phone by calling my office, 212-490-9535. And remember, of course, that New York City's upcoming elections for mayor, borough president, public advocate, controller, and your city council members are coming up with early voting starting October 25th to November 2nd. Election day is Tuesday, November 4th. And for information about voting, early voting, mail-in voting, televised debates, please consult NYCVotes, one word, .org or call 1-866-VOTE-NYC. Finally, remember to get your COVID and flu vaccines if you have not done so already. There's already data from around the country showing that people are not getting vaccinated because of all this strange false information out there, and they are getting sick. And we're all older or getting older, and it's just the right answer. Unless your doctor tells you you're one of those people who shouldn't get vaccines, and that's very rare. That means the rest of us really should get vaccines. And most of the drugstores in New York City are offering the vaccines. I spent last Saturday morning getting my shingles vaccine in one arm, my COVID in the next arm, and then I'll get flu. They said I shouldn't get all three on the same day. So again, thank you all for participating. And thank you again, Fred, for your great work for us every day. And if not for my staff's great work every day, you wouldn't even know I was your senator. So thank you, everybody. Have a good rest of the day. Take care.